You see my screen, Dr. Sabri?
Yes, Dr. Amr.
Very good. Are you ready? You want to start?
I think we should start.
Okay.
Other moderators are around. I mean, Mustafa, other moderators.
Yeah, Sahar is here. Peter Sawa is here. I'm not sure about Mustafa. Let's get started.
Okay.
Thank you, everyone, for joining us today for the GN conference. This is GN2 course. We had GN1 with primary GN 2 months ago. This course is the second one, and we are going to focus on the secondary GN. Again, this is an activity that we are doing between University of Mansoura Division of Nephrology and University of Kentucky. And this is sponsored by the International Society of Nephrology. We started this activity in January, and this is the third course. And the plan is to have this 2 days course every 2 months. Today, we have international speakers and eminent figures from USA and from Egypt. We have combination of case presentation and discussion, and also we have lectures. The first presentation we're going to start with will be presented by Lori Gale. It's a quiz with some questions she's going to discuss. She's not going to give you the answer right away, but by the end of today's meeting, she's going to discuss with you the answers. So also, I think on the WhatsApp group and in the chat, you will receive these questions. So please try to think about these questions. You still have more than 2 hours to try to answer these questions. Then by the end of today's meeting, Lori Gale Ikibar is going to give you the answer and the explanation for the answers. Then the first lecture will be by Dr. Muhammad Nassar, RBGN. It will be 25 minutes lecture, followed by 10 minutes discussion. Then it will be followed by a case and the case-based discussion with RBGN that will be presented by Asma Al-Imshati. Please, everybody mute yourself. Then this will be followed by a lecture from our dear professor, Dr. Muhammad Sabh, about anti-associated vasculitis. Again, 25 minutes of presentation, followed by 10 minutes of discussion. And this will be followed by another case presentation, a difficult case that will be presented from University of Kentucky by our fellow Adam Dosagi. And then by the end of the day, we'll summarize, we'll conclude, and Lori Gale is going to answer the quiz. Now, it's the time for Lori Gale to present her first quiz today. And as you see here, these are the speakers we have for today and tomorrow. This is from the USA side, Dr. Peter Sawaya from University of Kentucky, Dr. Brad Roven from Ohio State University, Patrick Neckman from University of Minnesota, Sadiq Ahmed from University of Kentucky, Sahar Kubar is one of the moderator, and she is from University of Minnesota. And here is the Mansoura, the Egypt side. Of course, our professor, Dr. Sabh, Dr. Ala Sabri, Dr. Dina Shaheen, she is a rheumatologist. Dr. Nassar is the one who is going to give us the presentation in a couple minutes about RBGN. Dr. Mustafa Ramadan Abdussalam and Dr. Ahmed Abdul Wahab, they are going to moderate today's and tomorrow's session. Without further ado, I'm going to stop my share, and Lori Gale should be able to share her screen and start telling us about the quiz she has for us. Go ahead, Lori Gill.
Hi, my name is Morgan.
I'm not able to hear her. Dorgale, we are not able to hear you.
Right.
Is me. I think there is a problem in her speaker.
If you can share this quiz, Rasha, in the chat group.
It's okay.
Thank you.
Can everybody hear me now?
Yes, we do. Please go ahead.
Okay, thank you. I was saying my name is Laura Gell. I'm one of the nephrology fellows at University of Kentucky. I just wanted to say thank you to Dr. Mohammed for putting this together, and good evening in Egypt from Kentucky. These test questions or quiz questions, I wanted to give credit to Dr. Tyler Sims. He is one of the nephrology fellows as well, and he was kind enough to put it together. I'm here to kind of just deliver it. All right, so we'll go through the slides, and then hopefully everybody will be able to answer these questions by the end of the conference today. So question number one, what is the expected immunofluorescence staining for anti-GBM disease? Our options are A, granular uptake of IgA, B, linear uptake of IgA, C, granular uptake of IgG, or D, linear uptake of IgG. The next set of questions kind of just asks a percentage question, and it kind of helps you realize the prevalence of these crescenteric GN. So number 2 asks, anti-GBM disease accounts for what percentage of crescenteric GN cases? A, 10 to 15%, B, 25 to 30%, C, 55 to 60%, or D, 80 to 85%. Question 3. What monoclonal antibody therapy is associated with subsequent development of anti-GBM? Is it A, bevacizumab, or B, alemtuzumab, C, adalimumab, or D, trastuzumab? And then question 4. What percentage of patients with anti-GBM disease will have pulmonary hemorrhage? Is it A, 10 to 20%, B, 20 to 40%, C, 40 to 60%, or D, 80 to 90%? The next 2 questions will ask you about the indication of plasmapheresis. So this question asks, for patients with anti-GBM disease who are dialysis independent or have diffuse alveolar hemorrhage, plasma exchange falls into which recommended category? So keep in mind that category 1 is reserved for conditions in which plasma exchange is considered first line, and all the way down to category 4, where plasma exchange is considered in the other end, where it's harmful or even contraindicated. Question 6 also asks the same thing, but these are for dialysis dependent. So for patients with anti-GBM disease who are dialysis dependent or present with serum creatinine greater than 5.7, plasma exchange falls into which recommended category? Again, the category 1 is, yes, it's indicated, that's first line, all the way down to category 4, where it's considered harmful or even contraindicated. Question 7, according to the data from the University of North Carolina, which clinical pathologic phenotype is more likely to relapse? A, PR-ANCA positive patients, B, MPO-ANCA positive patients, C, atypical ANCA or drug-induced ANCA, or D, both C-ANCA and P-ANCA. Question 8, MPA, GPA, or EGPA have a peak incidence in which of the following age groups? Is it A, 45 to 55 years old, B, 55 to 65 years old, C, 65 to 75 years old, or D, 75 to 85 years old? And then this is our final question. Approximately what percentage of patients with anti-GBM disease will have ANCA, typically MPO-ANCA positivity? Is it in the lower range, A, 15%, B, 35%, C, 55%, or D, 75%? And with that, we'll go over the answers towards the end. So I'm going to stop sharing now.
Very good, very good. Thank you so much, Lori Gill. These are great questions, and I think throughout the day, you will find some answers for these questions. So please think about these questions, and by the end of today's course, we are going to try to explain the possible right answers. Now it's a time to hear Dr. Muhammad Kamal Nassar, who is an associate professor at University of Mansoura. He's a great friend. He's very knowledgeable, very good speaker. He has a lot of interest in the GN, and he is a very good, teacher and very good speaker. And also he trains and he mentors a lot of students. Without further ado, please share your screen, Dr. Nassar. We are excited to hear this hot topic, the RBGN, and I think you'll be focusing more on the anti-GBM part, and you leave the ANCA-associated vasculitis for Dr. Sobh, and lupus and other things for Brad Rovin. So please go ahead and share your screen and start your presentation.
Thanks, Dr. Amr. Thanks, dear Professor Dr. Amr, for this invitation and these kind words. Actually, it is my great honor to be with you. Thank you so much. I have a problem, hold disabled participant screen sharing.
Okay, give me a second. Can you share right now? Very good. Go ahead, please.
Bismillah ar-Rahman ar-Rahim. Thank you, my all dear professors and colleagues, for giving me this great opportunity to be here. Today, inshallah, we'll talk about rapidly progressive glomerulonephritis. It is a clinical and pathological syndrome characterized by rapid loss of renal function over a very short period, days to weeks, with the presence of nephritic urine sediment, proteinuria, microscopic or macroscopic hematuria, dysmorphic RBCs and RBCs cast, and the histopathological characteristic on renal biopsy with the finding of crescent. So it is also called crescentic nephritis. RBGN is classified based on the histopathology and immune complex deposition into three main types. Type 1 with linear antibody deposition, type 2 granular immune complex deposition, and type 3 with post-immune, which means absence or few deposition, immune complex deposits. And these are the main three types. Type 1, which is the prototype of fated Goodbusher syndrome, representing about 10% of cases of rapidly progressive glomerulonephritis. The type 2, which is immune complex, and of course, lupus nephritis is one of the most common types of most common causes of this type. And this type represents 15 to 20% of cases. And the last, which is post-immune, and it's mainly constituted of ANCA-associated vasculitis, representing 60 to 80% of cases of rapid progressive glomerulonephritis. These are the causes of type 2, which is granular immune complex. It may be post-infectious, especially after streptococcal infection, collagen vascular diseases, lupus nephritis, Noxoline berbera, mixed cryoglobulinemia, membranoproliferative glomerulonephritis, fibrillary, and sometimes idiopathic. For type 3, which is post-immune, it represents almost 80 to 90% of patients, and they are mainly constituted of ANCA-associated vasculitis. There are three main types: GBA, microscopic polyangiitis, eosinophilic GBA, and some cases of drug-induced. It may be renal limited or systemic by many drugs, including hydralazine, levomizole, and other drugs. Whatever the cause or whatever the type, it is associated with glomerular capillary injury and increased permeability of the glomerular barrier, leading to inflammatory cells, fibrin and fibronectin, to enter the renal space. This leads to activation of podocytes, proliferation of epithelial cells, breaks in the Bowman's capsule, and the resultant influx of macrophages and cellular, and then fibrocellular and fibrous crescents, and then scarring if not treated adequately. Regarding the causes associated with high percentage of crescentic nephritis means at least 50% of the sample includes or contains crescents. The most aggressive disease or the most common disease associated with high percentage of high proportion of crescents is Anti-Gbm, followed by glomerulonephritis, lupus nephritis, Noxoline berbera, and IgA nephropathy according to this study. Regarding the histopathological characteristics, for type 1, it is associated with only extra capillary proliferation and no intracapillary proliferation. Type 2, which is the immune complex, both extra and intracapillary proliferation. Type 3, extracapillary and no intracapillary proliferation, but sometimes a mesangial proliferation in EGBA, granuloma in GBA, and infiltration of eosinophils in EGBA. Regarding the immunofluorescence, which is the characteristic or the definitive test to classify the rapid progressive glomerulonephritis, as we discussed before, type 1 is associated with linear deposits of immunoglobulin G along the glomerular basement membrane. Type 2, granular deposits of immunoglobulin and C3, and in lupus, it is full house. All specimens or all types of immunoglobulins and complements stain positive. And then type 3, which is post-immune, absent or few deposits of immunoglobulin and or C3. This disease, regarding the clinical picture, is associated with rapid decline in the renal function over weeks to months, with early clinical features are usually non-specific. Sometimes it may be present with hemoptysis and shortness of breath, maybe the first clinical feature if it is associated with alveolar hemorrhage. Anti-Gbm may present with pulmonary involvement in the form of diffuse alveolar hemorrhage, so the patient will complain of shortness of breath, cough, hemoptysis, along with the renal manifestations, including nephritis, hematuria, and edema. And the presence of extrarenal manifestations suggests the presence of either immune complex disorder or ANCA vasculitis, like general symptoms like fever, night sweats, weight loss, arthralgia, mucosa ulceration, scleritis, ENT manifestations like hearing impairment, otitis, epistaxis, nasal discharge, respiratory, if it is associated with alveolar hemorrhage, GIT manifestations due to ischemia, infarction, or pancreatitis with presentation of abdominal pain, CNS manifestations, and may even skin, including, of course, the palpable berbera ulcer and livido reticularis. It is very vital to address promptly and early because it is very aggressive disease and there is rapid loss of renal function and eventually renal failure. And once the patient develops renal failure, the patient will have the manifestations of renal failure, including fatigue, loss of appetite, nausea, vomiting, and decreased urine output. The diagnosis, we should be keen for diagnosis or anxious for diagnosis and suspect the condition. And once we suspect, we should do the necessary laboratory test for the major causes of rapid progressive glomerulonephritis, including urine analysis with the characteristic finding of active urinary sediment, of course, elevated serum creatinine, abnormal electrolyte like potassium, magnesium, and calcium. CBC, of course, was differential. Serology for Anti-Gbm, the antibody, and we'll discuss in details. Of course, the ANCA test, serology to rule out post-infections like ASO tetra for post-streptococcal infection, HIV, hepatitis B and C serology, complement level, serology for lupus, rheumatoid factor and cryoglobulin in suspected cases of cryoglobulinemia, chest X-ray and CT if you suspect diffuse alveolar hemorrhage, bronchoscopy also, ENT, and of course, the definitive diagnosis through histopathological examination through renal biopsy, which is the definitive diagnosis. So this is a rapid workup for a case of rapid progressive glomerulonephritis. At first, of course, the urinary sediment with the finding of glomerular hematuria in addition to proteinuria, chest X-ray, of course, ultrasound to exclude urological causes of hematuria and assess the renal size, microbiological tests like culture of the urine, blood, and sputum for suspected infections, complement level, speed-specific serology including ANCA and Anti-Gbm, and of course, the definitive is renal biopsy with immunohistochemical staining to detect the actual category of the rapid progressive glomerulonephritis. Of course, before you diagnose rapid progressive, you should exclude other causes of acute kidney injury like pre-renal acute kidney injury, acute tubular necrosis, obstructive uropathy, of course, nephrotic syndrome, hematuria due to other urological etiology, antiphospholipid antibody syndrome, and thrombotic microangiopathy. You should exclude all these cases or all these causes before you diagnose a rapid progressive glomerulonephritis. For treatment, you should start early because the untreated cases will rapidly progress to renal failure and the patient will pass to end-stage renal disease. Empirical treatment is proposed to start before the definitive diagnosis, especially in cases where the serology and the kidney biopsy are delayed due to any reasons like instability of the patient and so on. The empirical treatment includes pulse, intravenous dose of methylprednisolone, either 500 milligram or 1 gram for minimum of 3 days of 3 doses. Plasmapheresis may be considered, especially if the patient has alveolar hemorrhage. And later on, more specific treatment is considered once the definitive diagnosis is made. Of course, my dear Professor Subh will discuss the ANCA vasculitis in details. So, and I will in the second or the next part of the lecture discuss Anti-Gbm. So, the latter causes or the other causes like immune complex, of course, the treatment depends on the etiology, either lupus, IgA, vasculitis, and the others. And in post-streptococcal glomerulonephritis usually recover spontaneously, and very, very rarely glucocorticoid is indicated for severe crescentic RBGM. Drug-associated GN also removes or recovers spontaneously after stopping the drug, and sometimes we need treatment. And in double positive cases with ANCA and Anti-Gbm, the treatment should include plasmapheresis. What about guidelines? I think this is the only guidelines I find focusing on rapid progressive glomerulonephritis. It is the Japanese guidelines. They proposed a clinical grading scoring system according to the serum creatinine, and this is the clinical score for the different grades of serum creatinine according to the age, according to lung involvement, and according to serum CRP. And these are the grades according to the total score, grade 1 to 4. They classified the treatment according to this class. For class 1 and 2, if the patient is more than 70 years and or not on dialysis, he will receive A or B according to the clinical grade. If the prednisolone followed by oral corticosteroids, and C, pulse methylprednisolone followed by oral corticosteroids and oral cyclophosphamide. What about the prognosis or the outcome? This review included more than 500 patients with biopsy-proven crescentic nephritis. They find that the serum creatinine was highest for type 1 for Anti-Gbn, followed by type 3, and the lowest serum creatinine was for type 2, which is immune complex. And similarly, acute kidney injury was more prevalent in type 1 in about 87%, and the same for type 3, and the lowest percent of acute kidney injury was for type 2. So it seems that type 1 and 3 are very aggressive, and type 2 is less aggressive compared to the other types. Regarding the renal survival, like here, the best survival was for type 2, followed by type 3, and then type 1, which is Anti-Gbm disease having the lowest survival. And it did not differ between the type 3 either ANCA positive or ANCA negative. It was the same outcome or the same renal survival for both types. Is there novel predictors for the outcome in crescentic nephritis? This study included 114 patients diagnosed with crescentic glomerulonephritis. Most of them were positive for ANCA and Anti-Gbm. They tested novel histopathological predictors, and they find that the best prognosis was for focal histopathological type, followed by crescentic, mixed, and the worst prognosis was, of course, for sclerotic type. Sclerotic type had the lowest renal survival. And also they proposed that the higher the grade of arteriosclerosis, the lower the renal survival. And they included a novel histopathological predictor that was the tertiary lymphoid organ, which means the focal lymphoid aggregates, like in these arrows, focal lymphoid aggregates. And they find that the presence of tertiary lymphoid organ was associated with lower renal survival. So these are some of the novel histopathological predictors for this disease, which is rapid progressive glomerulonephritis. What about the complications? The complications may be disease-related, like, of course, pulmonary hemorrhage was sometimes very aggressive and associated with mortality, especially in cases with Anti-Gbn. Upper and lower respiratory tract involvement associated with Anti-Gbn, and the various immune complex deposition glomerulonephritis present with extrarenal manifestations. The most common type here in Egypt, of course, is lupus nephritis, can present with many extrarenal involvement, including serositis, cerebritis, and skin lesions. The treatment itself may be associated with complications, like opportunistic infections, which are sometimes life-threatening. Cyclophosphamide is associated with cystitis and hematuria, and the plasmapheresis, of course, sometimes is associated with high risk of bleeding-related complications. Okay, so this was the first part of the first half of this lecture, which is rapid progressive glomerulonephritis, regarding the different types, histopathological diagnosis, and general treatment. The second part we will talk about or focus on the Anti-Gbm or Goodbuster disease. So let's start by this historical perspective. The association between pulmonary hemorrhage and glomerulonephritis was first reported by Ernest Goodbuster. This was an American pathologist who, while studying the influenza pandemic in 1919, described a case of a patient with progressive and fatal disease in which GN was associated with pulmonary hemorrhage and hemoptysis. Later on in 1955, Parkin and the colleagues described another 3 cases of lung hemorrhage and nephritis. And in 1958, Stanton and Tang reported 9 patients with pulmonary hemorrhage and glomerulonephritis, like the description of Goodbuster, and suggested the eponym Goodbuster syndrome for this clinical constellation. So this was the first nomenclature of Goodbuster syndrome, referring to the presence of alveolar hemorrhage or pulmonary hemorrhage and glomerulonephritis. Later on in 1967, demonstrated Lerner and colleagues demonstrated Anti-Gbm antibodies in the sera and or the kidneys of 6 patients with GN, and showed that these antibodies combine with the host glomerular basement membrane. And the first comprehensive clinical description was described in 1973 of 63 cases in which the evidence of anti-Gbm antibody by immunofluorescence and elution of a specific antibody and or detection of the circulating antibody in the serum was done. And this finding established the causal relationship between anti-Gbm antibodies and the glomerular disease in a specific subset of patients with Ghostbuster syndrome. So this was the first or the comprehensive clinical description of this syndrome. This is the structure of the glomerular basement membrane, which is type 4 collagen. It is composed of 3 types of a chain, alpha 3 and alpha 4 and alpha 5. They compromise the hexamer, and this is the structure, the detailed structure of the glomerular basement membrane. What about the nomenclature? You should differentiate between different terms associated with this disorder. At first, pulmonary renal syndrome. What's pulmonary renal syndrome? It is combined renal and respiratory failure. It may be caused by immunologic and non-immunologic cause, and these are the non-immune cause. Maybe due to pulmonary edema and acute kidney injury, either renal or cardiac disease, maybe infective, different type of infections, or others like acute respiratory distress syndrome with renal failure and many other causes. So these are the non-immune causes of pulmonary renal syndrome. What is Ghostbuster syndrome? Ghostbuster syndrome means presence of rapid progressive glomerulonephritis and alveolar hemorrhage. And these are the causes. Ghostbuster disease is one of the causes, and these are the rest of causes. The different types of vasculitis, the immune complex disorder like systemic lupus, IgA vasculitis, Berbera-Behçet, and other causes. What about Anti-Gbm disease? Anti-Gbm disease is a disease associated with antibodies specific for any component of the glomerular basement membrane. And the most important causes are Ghostbuster disease and Alport syndrome post-transplant Anti-Gbm disease. So what is Ghostbuster disease? Ghostbuster disease is a disease caused by autoantibodies specific for non-collagenous domain of alpha-3 chain of type 4 collagen. This is the Ghostbuster disease. So Ghostbuster disease is one type of Anti-Gbm disease, and the Anti-Gbm disease is one of the types or one of the causes of the Ghostbuster syndrome. So this is the important terms associated with this disorder. What about predisposing factors? Some predisposing factors have been detected or have been found to be associated with the presentation of this disease. Possibly inducing autoimmune response like presence of systemic small vessel vasculitis affecting the glomeruli, leading to exposure of the epitopes, membranous nephropathy, lysotripsy for renal stones, renal obstruction, and use of alemtuzumab syrup, and this is one of the MCQ questions. The second precipitating factors for pulmonary hemorrhage: cigarette smoking, hydrocarbon exposure, fluid overload, and pulmonary infection. Whatever the cause, there are some predisposing factors, like we see, leading to dissociation of the hexamer, the structure of the glomerular basement membrane, causing exposure of the pathogenic epitopes, and in genetically predisposed patients, there is autoreactivity to this engine and development of Anti-Gbm antibodies and renal and lung injury. What about the epidemiology of this disease? It is a rare condition with incidence of 1 to 2 per million per year in European populations. It has been described in all racial groups, but is rare in African population. It has a bimodal distribution of age with 2 peaks, the first in the 3rd and the second in the 7th decade of life. There is male predominance in the first peak and slight female predominance in those presenting later in life in the 7th decade. Regarding the clinical features, 80 to 90% of patients would present with features of rapid progressive glomerulonephritis. Uh, 40 to 60% will have concurrent lung hemorrhage, and this is also one of the questions. And a small minority of patients may present with isolated pulmonary disease, but it is too much rare. For the diagnosis, we should have the detected anti-Gbm antibodies either in the serum or deposited in the tissue by kidney biopsy. along with the histopathological features of crescentic glomerulonephritis were with or without evidence of alveolar hemorrhage. Regarding the serologic test, it is an urgent, of course, laboratory test and should be rapidly available within 24 hours to avoid delay in treatment, which will be associated with progression to end-stage renal disease. But we should note that approximately 10% of patients don't have identifiable circulating antibodies with the conventional assays, and so the serological testing should not rule out and should not be the sole method for diagnosis when kidney biopsy is available. It can be negative in approximately 10% of patients. What about deposited antibody, which is more specific by, of course, by detection by the immunofluorescence examination of the kidney tissue and the typical finding of linear deposition of IgG. But we should take care in cases of severe glomerular inflammation, it may be undetected because the architecture is disrupted, okay? And lung biopsy is not informative, rarely informative and rarely done. So finding of Anti-Gbm with linear deposition of IgG along the glomerular basement membrane with this ribbon-like appearance is very specific or very characteristic for anti-Gbm disease. And we should note that there are some other causes for associated with non-specific binding, like diabetes, like cadaver kidney, like light chain disease, fibrillary, and sometimes of SLE. We should also take this issue. Of course, the characteristic histopathological finding with fibrinoid and then crescent formation, crescent and fibrinoid necrosis, and this circumferential crescent with disruption of the Bowman's capsule. And this is very specific. And the crescent formation is the histopathological hallmark for this disease. And about 95% of patients will have evidence of crescent on kidney biopsy. And 80% of patients, at least 50 or half of the glomeruli are affected. So it is associated with high percentage of crescent formation, approximately 75%. The proportion of crescent correlates strongly with the degree of renal impairment at presentation. They are typically of uniform age, and this is very important. If you find the crescent they are of the same age, they are all cellular or fibrocellular or cellular, in contrast to other cases which have mixture of cellular, fibrocellular, or fibrous crescent. And of course, in normal or normally appearing glomeruli, you can find fibrinoid necrosis. For alveolar hemorrhage, of course, you should suspect by the necessary laboratory test, radiological test, chest X-ray, and CT. The definitive diagnosis is through bronchoalveolar lavage and the finding of hemosiderin-laden macrophages, but it is not usually done for patient the condition can be not suitable for this. Pulmonary function test with the use of alveolar carbon monoxide transfer factor can differentiate between alveolar hemorrhage and other causes of pulmonary infiltration, but again, the utility may be limited if the clinical condition of patient is unwell. So this was the diagnosis for Anti-Gbm disease. So the hallmark for diagnosis is the detection of the antibody either in the serum or the tissue, the characteristic histopathological finding, and the detection of lung hemorrhage, which can present in 40 to 60% of patients. What about treatment or therapeutic approaches for this case? For induction, of course, we will use the glucocorticoids with the initial high dose oral steroids, followed by subsequent tapering. The oral cyclophosphamide 2 to 3 milligram per kilogram, and should be adjusted for the kidney function and the age of the patient and white blood cell count, and of course, the therapeutic plasma exchange. Another alternative used in some centers using initial methylprednisolone pulse steroid. It has no proven efficacy, and it may be associated with increased frequency of new onset diabetes and severe infections. Using pulse cyclophosphamide, it is limited and it's not widely approved, but in Egypt here we use it because unfortunately we don't have oral cyclophosphamide. Rituximab, sometimes used in cases with unresponse to treatment, and sometimes it can be used subsequently with the cyclophosphamide. Immunoadsorption can be used in some cases, and I will have a slide on the immunoadsorption. For the maintenance treatment, the Anti-Gbm disease alone is not does not need maintenance treatment because it is not associated with frequent relapse. But in double positive cases with presence of positive ANCA and Anti-Gbm, the patient should receive maintenance immunosuppression either azathioprine or monthly infusions of rituximab. Another agent, novel agent, imlifidase, and it's not approved so far, and we'll have a slide on it. And prophylaxis is very important, especially for or during the use of the high dose of immunosuppression like pneumocystis juveri prophylaxis with trimesoprim sulfamethoxazole, vitamin D, calcium to prevent osteoporosis, proton pump inhibitors or H2 inhibitors, and amoxiclav if the imlifidase is used. What about plasma exchange or therapeutic plasma exchange? According to the American Society of Apheresis guidelines, it is recommended as a grade 1 recommendation if the patient has alveolar hemorrhage and dialysis independence. While the dialysis dependent patient without pulmonary hemorrhage, it received a grade 3 recommendation. And these were two questions. Okay. Why we don't give the dialysis patients therapeutic plasma exchange? Because the individual characteristics should be considered as risk of immunosuppression on dialysis. The kidney biopsy might give me information. If we found the high amount of sclerotic glomerular anticrescent close to 100%, it would indicate irreversible kidney damage, and the patient will not recover and will not get benefit from therapeutic plasma exchange. And patients presenting with oliguria or anuria at least 48 hours at presentation have worse prognosis, and this should be also included in individualized decision making. In clinical practice, most centers will start by the immunosuppression and total and therapeutic plasma exchange, waiting for the results of the antibody and the biopsy, and then they will decide to continue or discontinue according to some parameters. I will discuss it few slides. What about immune adsorption, which can be used an alternative to therapeutic plasma exchange? The clinical trial data are missing, but it has some benefits or some advantage over the therapeutic plasma exchange. It can process the individual plasma without addition of substitutes such as albumin or fresh frozen plasma, thus minimizing the risk of allergic reaction. It can be performed without the placement of central venous catheter, reducing the risk of central line infection. The exchanged volume can be increased to 2.5 to 3 times the plasma volume in comparison to 1 and maximally 1.5 times during the plasma exchange, and it might lead also to more reduction of the IgG level. Who will benefit from switch to immune adsorption? Patient with high body weight and the patient with anti-Gbm antibody levels. These are the patients that will get benefit from shifting from the therapeutic plasma exchange to immune adsorption. Another agent, which is imlifidase, which is IgG degrading enzyme of Streptococcus pyogenes, it cleaves the heavy chain of human IgG, preventing its binding of the antibody to the glomerular basement membrane. And this study was for this molecule, and it was published in the Kidney Week 2020. And they concluded that the imlifidase leads to rapid clearance of Anti-Gbm, which seems to widen the window of opportunity for treatment, thereby increasing the chance of renal survival in difficult to treat patients with anti-Gbm disease. However, it is not approved so far, and phase 3 trial is necessary, and it can associated with relapse, and the second dose is currently discouraged to the fear of immune complex mediated hypersensitivity and the formation of neutralizing antibody. What about rituximab? And I will
Dr. Nassar, sorry to interrupt,
okay.
We are 10 minutes behind, so if we can just wrap it up quickly.
Okay, thank you. So rapidly, the rituximab as a viable option for patient who does not respond to cyclophosphamide, and currently there is not enough data to support the use of first-line agent. Regarding the renal survival, it is associated with the use of, and this was the largest cohort of the patients from the Hammersmith Hospital. It was associated with acceptable survival around 75% after 5 years. But we should note that the patient with high serum creatinine more than 500 micromole per liter were associated with much lower survival, renal survival compared with the patient with lower creatinine, and also the patient survived. So I will finish with this slide. When you decide not to treat the good posture disease aggressively, these are factors. When you find it, you should think about against aggressive treatment, like absence of pulmonary hemorrhage, presence of oliguria, high serum creatinine and ANCA negative, severe damage on kidney biopsy, no desire for early kidney transplantation, and high risk of immunosuppression. You should decide, or you should think against the aggressive treatment. But if there is pulmonary hemorrhage, absence of oliguria, lower serum creatinine, dialysis independency, and not associated disease, you should start with aggressive immunosuppression. I think I will conclude with this, and thank you, and sorry for prolongation. Thank you so much.
Thank you, Dr. Nassar. Thank you so much for a very informative lecture. I'm sorry we had to cut you short, but we had to just abide with the schedule. Good afternoon, everyone. Good evening for the people on the other side of the world. I will open the floor for, probably will have like one or two questions. I'll start with the question from Dr. Sawaya. He's asking, what's the effect of active smoking on the incidence of alveolar hemorrhage in anti-Gbm disease? And if we know what is the current smoking prevalence in Egypt per se?
Okay. Of course, cigarette smoking is one of the most important predisposing factors for alveolar hemorrhage, because it leads to exposure of the epitopes and induction of the autoimmune process. So it's very important risk factor, and the most of the patients presenting with alveolar hemorrhage are cigarette smokers. Okay, the prevalence of smoking in Egypt, I don't know an average, but unfortunately it is a high prevalence. I'm not a smoker, but in Egypt we have a very high prevalence of cigarette smoking.
Besides the hubble bubble smoking, I guess this is a whole different pandemic.
Yes.
Any other questions? If any of the audience would like to unmute themselves and ask their questions.
We can't. We control them, Sahar.
So okay. So I have a question. Like whenever you have anti-Gbm disease, if you have a biopsy full of crescents, the recommendation is not. If a patient doesn't have any alveolar hemorrhage, the recommendation is not to give any immunosuppressant medications. There is like two problems, I think, with that, whether you have the guts to do that or not, especially that like usually the results for anti-Gbm antibodies are usually delayed. So they are not like, in some centers, I know they are not like coming the same day or the next day. And like sometimes even the biopsy that you do, like you do not have, sometimes you do not have rapid access to biopsy results. So what is your take on that?
Actually, it is a very tricky issue. We face a lot of cases with rapid progressive glomerulonephritis and this picture. Okay, of course, if it is most of the sample is associated with fibrocellular or fibrous crescent, I will not treat aggressively. Okay, if the patient is young age and as very very rapid progression, maybe sometimes seeking for early kidney transplantation, I will try aggressive treatment even if all the sample is associated with crescent. It depends upon the clinical situation, the general condition for the patient. I think it will be a balance between the immunosuppression and side effect of immunosuppression. And we can change the decision after 3 to 4 days according to the clinical situation and the improvement of the patient.
Okay, definitely medicine is an art. Thank you, Dr. Nassar. So it gives me the pleasure to now introduce Dr. Asma Emshati. Dr. Emshati will present a very interesting case, and then this will be followed by a case discussion for 10 or 15 minutes. So thank you, Dr. Emshati.
Thank you, Doctor. all my professors. It's my great honor to participate in this meeting. I will discuss a case presentation about RPGN, a male patient, 46-year-old male, married with 2 offspring with no special habit. Came to outpatient clinic November 2017, complaining of lower limb edema and decreased urine output with no past medical history. 4 days prior to the examination, presented with common cold-like symptoms and received the amoxicillin, fluoxetine, and anti-flu-like combination, loratadine, pseudoephedrine, and paracetamol. On examination, blood pressure was 140/80, pulse and temperature were normal, skin, chest, abdomen, no abnormality, with mild lower limb edema. 4 days later, he had abdominal pain, oliguria, lower limb edema, and elevated blood pressure. He was given proton pump inhibitors and diuretics. Laboratory investigation showing microcytic hypochromic anemia with mild neutrophilia, urine analysis showing proteinuria +2, RBCs over 100, and pus cells 75/80. 24-hour urine protein was 1.6 gram. Creatinine was done for the first time, was 4.2. Ultrasound showing normal kidneys. So the patient started empirical steroid, oral prednisolone 40 milligram, and workup for glomerulonephritis was requested, and renal biopsy was done. 2 days later, progressive oligoanuria and increased serum creatinine to 7.2. So the patient was admitted for received pulse methylprednisolone 1 gram for 3 days. Immunology workup was done, ASO, urine and blood culture, biology, C3 and C4, and NW strand, ANCA-PLC, Anti-Gbm, all were negative. Renal biopsy showing hematoxin and eosine stain, 14 glomeruli per section, glomeruli showing 7 glomeruli showing cellular crescent, diffuse mesangial hypercellularity with frequent neutrophilic infiltration, and regular thickening of the basement membrane. Tubules show focal acute tubular injury, and some tubules show degenerated epithelial cells. Interstitial showing interstitial edema, focal inflammatory infiltrate in the form of lymphocyte, plasma cell, and neutrophil. A picture of diffuse proliferative glomerulonephritis with frequent neutrophilic infiltration and cellular crescent. Picture of post-infectious glomerulonephritis with crescent. And the immunofluorescence showing IgG and C3 diffuse GBM deposits and the mesangial deposits. On the next day's patient blood film was done, and no abnormal cells, non-contrast CT chest and abdomen were free, transesophageal echo was free, ENT consultation for any septic foci, and procalcitonin was negative, total leukocytic count still increased to 23.9. The patient after pulse steroid showed in clinical and lab improvement in the form of hematuria disappear, increased urine output, and decreased serum creatinine to 1.06. But the total leukocytic count is still increasing with steroid, mostly leukomoid reaction. Proteinuria disappear, and the RBCs decreased to 20 to 25. So it is post-infectious glomerulonephritis without localization of source of infection. Can you give immunosuppression with this increased total leukocytic count? And what is the explanation of immune complex in immunohistochemistry? On the next follow-up, a patient developed tinea pedis and acne. So
I guess like if we can stop here and just like tackle one of these few questions. If you would go back to the biopsy slides, if you please. So in summary, this is a 40-year-old male who was previously healthy, actually, and he developed what looks like a rapidly progressive glomerulonephritis, active urine sediment, and a rapid rise in his creatinine. So this is a rapid progressive GN. Yes. If you look at this biopsy, really there is a significant proliferation, but it seems that the proliferation is not like only restricted to the mesangial areas. There is some endocapillary hypercellularity as well. And what's like really also striking on this biopsy is that there is significant thickening of the glomerular basement membrane. In the first slide, there is definitely, and this thickening is actually at 6 o'clock. It definitely, this thickening indicates that there is like an immune complex that is showing on this kidney biopsy. There is a crescent on this the other picture here, and it is really segmental, and I don't know if it definitely represents the 7 crescents that he has, but it's really a smaller crescent. So the first question was like, is this post-infectious GN with all the negative serology he had? So the way I look at the way I would like to look at crescentic GN is actually I divide them in my mind into 3 categories. First of all, is this an immune complex mediated GN? Second, like, is this anti-Gbm disease? And the third is whether this is a post-immune glomerulonephritis. So the infection-related, the immune complex-related GN goes under that the lupus nephritis, the crescentic IgA, and the infection-associated. I like to call it infection-associated GN rather than post-infectious GN. But there are other categories that we often forget, like, and Dr. Nassar have mentioned in his presentation. There is like the fibrillar GN, and particularly the MPGN pattern of fibrillar GN. There is like the hypocomplementemic urticaria GN and the cryoglobulinemic GN. So all that goes into the differential. Now this guy has all these are negative. And the fact that he had really immune complex deposits on his makes like ANCA less ANCA associated, like really less likely. So just wanted to throw that here, and we can continue. Thank you.
Okay, thank you, Doctor. On the next follow-up, patient developed diabetes and acne, so the dose of steroid decreased to 40 milligrams, but total leukocytic count still high, 21.1, and with gradual decrease of steroid, total leukocytic count decreased. The patient developed first relapse on March 2018. Patient was on steroid 30 milligrams, then clinical relapse occurred in the form of prodroma, oliguria, hematuria, and rising serum creatinine. Serum creatinine rises from 1.9 to 3.3, then 3.9. Urine analysis showing RBCs 80 to 90, and the total leukocytic count increased again to 26. So the patient is readmitted again, and the anti-Lupus trend repeated again. Patient started to receive pulse steroid 0.5 gram for 3 days, and the pulse cyclophosphamide 0.56 dose bi-weekly. And the patient starts MMF 1 gram per day. The patient is on a high dose of steroid till now, and the gradual decrease of steroid to 17.5 with remission. So the creatinine started to decrease 1.9 to 1.8, then to 1.3. Then the patient received another relapse. The patient was on steroid 17.5. MMF 1.1 gram. A clinical relapse occurred again in the form of prodroma, hematuria, oliguria, and increased white serum creatinine. Creatinine rise from 1.8 to 3.3 and jumped to 10 milligram. Urine analysis showing protein plus 2 RBCs over 100. So the patient started pulse steroid 0.5 for 3 days. But the patient refused rituximab, so pulse of cyclophosphamide 6 doses was given, 500 milligram bi-weekly, then 3 doses every 3 months was added to his regimen, with gradual decrease of the steroid to 12.5. And this regimen continued for 1 year. The last dose of cyclophosphamide was 8/7/2020, and steroid decreased to 12.5, and the MMF was 1.5. The serum creatinine decreased from 10 to 6, and then decreased gradually to 1.4, and the hematuria improved. The patient had another relapse On January 2020, relapse occurred again in the same form of protrauma, hematuria, rising serum creates from 2.8 to 3.5. So the patient started pulse steroid again 0.5 for 3 days, and the patient every time have marvelous response on steroid. The patient refused another renal biopsy and refused to retake rituximab for second time. So he continued treatment for 2 months on steroid 60 milligram and MMF 1.5. And around this time, his serum creatinine was 2.8 to 3, which is new basal creatinine. And 2 weeks later, patient complained of cough with sputum, fever. So patient diagnosed COVID-19 and received the treatment. A few days, fever subsided and chest condition improved. Another clinical relapse occurred in the form of leukorrhea hematuria rising creates to 5.5. This time, a relapse occurred while the patient was on steroid 60 milligram. He was admitted and received pulse steroid 0.5 for 3 days. And then after senior chest consultation and high resolution CT chest, no contraindication for receiving rituximab. So the patient was conceived to receive rituximab, but refused another renal biopsy. Received the rituximab 500 milligram for doses weekly, and the creatinine dropped again from 5.5 to 3.3. And the last relapse occurring at Mayo 2021, during the tapering of the steroid from 60 to 40 milligrams, the last relapse occurred in the same form. So the patient was admitted to receive pulse steroid again, but unfortunately, second attack of COVID-19. So he didn't receive pulse steroid and received antiviral treatment for COVID and refused to chest compartment. Then died due to respiratory failure without need of renal replacement therapy. So in brief, a patient on every have 5 relapses. The first relapse received the pulse steroid, cyclophosphamide, and MMF. Second relapse, which refused rituximab, received pulse steroid again, pulse cyclophosphamide for 1 year. The third relapse received pulse steroid and then attack of COVID. Then relapse occurred. Received rituximab, then another attack of COVID, then the patient died. So could COVID pandemic change our decision for the treatment of these patients? And what's the cause of recurrent relapse and how can we deal with such a frequent relapse? And thank you.
I think the big question, thank you so much. I think the big question is, what does this patient have? We have to have a diagnosis. Yeah, I'm looking at the chat here. So Dr. Osman says like 5 relapses with 1 biopsy without EM or IF. So this is like a very important comment. So yeah, I think it would be nice to know. It would be nice to know the exact immunofluorescence on this. The pattern of immunofluorescence is very important. For example, we know like with anti-Gbm, it's pretty linear, but if this guy has like fibrillary, it could have been a smudged immunofluorescence. And the other question is whether do we have an EM electron microscopy on this patient?
No, he didn't make it. If immunofluorescence showing IgG deposit and C3 deposition on glomerular basement membrane, but the patient refused another renal biopsy.
Yeah, I mean the issue with this patient is that like all his serological workup was negative. Do we have any monoclonal? It would be nice to know if he had any workup for monoclonal gammopathy.
You mean they mentioned that there is no immunoglobulin monoclonal in the blood, in the serum, but yes. We don't know if the immunofluorescence, do you have a kappa and lambda, and if there is one more than the other or the other is absent? You don't have that, do you? Because again, that could be, monoclonal immunoglobulin,
right.
FGN with monoclonal immunoglobulin. We don't have that. Another question I have, if I may, Sahar, is how rapidly is the creatinine bumping to 10? I know these are relapses, even in the most aggressive crescentic GN, which this guy doesn't have that, that diffuse proliferation and a lot, I don't know what percentage of crescent, but they were like a smaller crescent. Even with that, creatinine doesn't bump like this to 10 so rapidly. So do you know the time between 1 to 10 that the creatinine has risen? And the reason I mentioned that, because you're also showing ATN features and pretty extensive ATN features. And that every time you say when he relapses, he has hematuria. And that reminds me of the acute renal injury that happens in IgA nephropathy, for example, when they have heme-induced AKI in that situation. Is it a gross hematuria that when he recurs, or just you are mentioning it here microscopically?
No, just microscopic hematuria.
I see. Because usually the other one would be gross hematuria that they have.
So in the chat, Dr. Umayma Abdelaziz mentions that it's really unusual for post-infectious GN to have such relapses. Yeah, it would be. So I think it would be nice to first of all to have like silver stains to see if there is any like double contouring in this patient. He did have an MPGN pattern on his pathology. It would be nice to have like the to see if there is any monoclonality on his biopsy, because that will take us towards another perspective, but the fact that he responded to immunosuppressants and not plasma targeted therapies makes monoclonality less likely. But I would be concerned about fibrillary GN in these patients, and especially the MPGN type of fibrillary. And usually these people have both kappa and lambda on their biopsies, and the way to diagnose it is actually to do immunohistochemistry for DNA BG9. So yeah, I would like to know if these things I think will help. Doesn't look like it's anti-Gbm disease or.
Dr. Sahar, if you allow me to comment.
No, sorry.
Hello, this is Dr. Sabri from Mansoura. If you allow me to comment.
Sure.
Actually, it is a very puzzling case, a case of what was diagnosed first as post-infectious glomerulonephritis, which I don't think this is the case. With about 5 relapses, nothing we can catch in our hands, either to go in post-infectious direction or an immunological induced RBGN. The first question, are we missing something in the investigation? Because I don't think cases of post-infectious glomerulonephritis after exclusion of all causes can be relapsed in such a manner. And most of the relapses actually are good responder to immunosuppression, whatever it is steroid, whatever it is rituximab. So the question is, I don't think, or my suggestion, I don't think it will be a post-infectious glomerulonephritis. The second question, are we missing something in the investigation? It seems like an immune-mediated disease which goes up without immunosuppression and easily controlled after giving immunosuppression. This is my first question. Are we missing something here in the investigation, is the lab investigation, or even in the light microscope? Second, for question of asthma, could COVID pandemic change our decision for treatment? I don't know if we already over immunosuppress this patient and we exposed him to 2 attacks of COVID or not. What do you think?
I think definitely the COVID pandemic has, in general, the COVID pandemic has affected. We were more hesitant to give give rituximab in these patients, but these patients obviously responded to cyclophosphamide. He was always responding to pulse steroids. So even before the COVID pandemic, he did receive adequate immunosuppression, which seems that like he was really responding to. But to answer your question in general, like it's a double-edged sword. Like with the rituximab in pandemics, we know that like there are three issues, as you all know. First of all, I think like people has been hesitant, but the problem is that half of people who had already vasculitis and they were on maintenance rituximab, they had flare up of their vasculitis. And when the vaccines were introduced, like we were also hesitant to give rituximab because we wanted people to build immunity to the vaccine. So it's not an easy answer. It's not an easy answer.
Dr. Sabri, I really myself struggled very much with that, and many of my patients. And if we look at the literature from Colombia and things, they were reassuring us that, hey, you know, we can go ahead immunosuppress them. You know, they do well. I think there's a couple studies in that regard, but I'm still very skeptical. And the way I look at it, I sit with my patient, and my patient answers me. I see what kind of lifestyle they have. I have a guy, Tyler is not with us, that I follow with him. Again, he had membranous, but also significant diabetic in addition to membranous. He's morbidly obese, and he works in the jail. He goes, in very exposed. He has to go every day, and he's exposed to all kind of people. And he was really, really high risk and really morbidly obese. I'm talking about like 300 plus pounds. That's 150 more kilos. So I, when I put those risks and benefit together, I elected, no, I'm not giving rituximab. And I think that's what is going to end up being, individualized. We don't know if this gentleman was obese, was what other risk factor he has to get a severe COVID disease. That really plays into my mind what I would do. There are a couple on the chat that I saw that they need an answer. One is the fact that they said no kappa or no lambda. That is not, it cannot be. You don't say it that way. We say kappa and lambda are stained the same way because you have immunoglobulin there, so they have kappa and lambda in it by definition, unless it is just heavy chain deposition. So it should be said kappa and lambda are positive, but they are equal in intensity. And that's what is missing in this biopsy that we would like to answer. So, and the other question also I saw in what is this could be C3 nephropathy, glomerulonephritis. And again, that goes back to the immunofluorescence. To define it, yes, you can have IgG, you can have mild IgG, let's say +1, but you'll have +4 C3, and then that you call it C3 nephropathy. It's at least they say 2 class of intensity between the two. So it doesn't have to be completely negative for IgG and only C3. And that kind of detail we would like to see in the immunofluorescence, whether to call it C3 glomerulonephritis or not. These two questions I saw in the chat.
So, Dr. Sawaya, I think we can move forward with the schedule.
Absolutely. I think our next speaker, before attending these conferences, I know Amr Al-Husseini now for how many years, Amr? I think 2012, if I don't recall. So 10 years and plus. And I've heard about Dr. Subh from Dr. Al-Husseini many times. And last time he presented to us and he commented with us. So I'm really excited again to hear Dr. Mohammed Subh presenting to us ANCA-associated vasculitis, and then followed by another case of RPGN that we may dissect. Dr. Sobha, we appreciate your time to be with us.
Good evening, everybody. First, I'm thankful to my dear friend Amr Husseini, and thankful for my friends in Kentucky University. I'm going to talk today and discuss very important issue, which is ANCA-associated vasculitis, and I'm going to present the most up-to-date formulation of this disease. Okay, we all know that the kidneys are targets for a variety of systemic vasculitis, especially those that affect the small vessel. Okay, vasculitis can be categorized as large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. Okay, this is the well-known revised international shopping wheel consensus conference nomenclature of vasculitis. We know it can be classified as large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. And of course, as we observe here, there is usually there is an area of overlap between these types of vasculitis. Today, we are going to focus on small vessel vasculitis, especially the ANCA-associated small vessel vasculitis, which can be classified as, I'm going to explain now, microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. Now we come to the small vessel vasculitis. It is a necrotizing polyangiitis that affects predominantly vessels smaller than arteries, including capillaries, venule, and arteriole. However, arteries also may be involved. The most common renal target for small vessel vasculitis are glomerular capillaries, and therefore the most common renal clinical manifestation are those of Now we come to the clinical pathology. We know that the variants of post-immune small vessel vasculitis are categorized on the basis of a clinical, laboratory, and pathological feature as the following. Small vessel polyangiitis, it is a post-immune, i.e. no immune deposits, small vessel vasculitis occurring in absence of evidence of necrotizing granulomatosis. While the other two lesions are characterized by presence of necrotizing glomerulonephritis. The granulomatosis with polyangiitis, which was well known as vaginal granulomatosis, mostly affect the respiratory tract. The eosinophilic granulomatosis with polyangiitis, in the past we call it Church-Strauss disease. It is a post-immune vasculitis associated with asthma, eosinophilia, and necrotizing granulomatous inflammation. So small vessel, no granulomatosis, no granulomatosis, but the other two types are with granulomatosis. These two types, microscopic polyangiitis and vaginal, and less frequently Church-Strauss, share an indistinguishable pattern of glomerulonephritis, that is expression of vasculitis in glomerular capillaries. In the acute phase, the GN usually has necrosis and crescent formation and an absence or very little immune globulin deposits, and always distinguished as post-immune crescentic glomerulonephritis. When this lesion is in the kidney only and no systemic manifestation, we may say it is renal limited vasculitis. Vagular, i.e. granulomatous cholangiitis, and microscopic and eosinophilic usually begin during the 5th, 6th, and 7th decade of life, but might occur at any age. Generalized non-specific manifestation of systemic inflammatory disease such as fever, malaise, anorexia, weight loss, myalgia, and arthralgia all may be present as systemic manifestation. Many patients with vasculitis trace the onset of their disease to a flu-like illness. So usually an infection can this vasculitis, but also some drugs such hydralazine, propylthiouracil, penicillamine, and illicit cocaine adulterated levamisole with levamisole can induce ANCA-associated vasculitis. Manifestation of upper respiratory tract disease include subglottic stenosis, sinusitis, rhinitis, nasal septal collapse, otitis media, and ocular inflammation. These features are most common in granulomatous polyangiitis, but may occur in eosinophilic and microscopic. The upper respiratory inflammation and microscopic polyangiitis is caused by angiitis alone without granuloma formation. Now we come to cardiac disease. Is identified in approximately 50% of patients with eosinophilic polyangiitis, but less common than 20% in patients with the other two lesions. Manifestation range from transient heart block, ventricular hypokinesia, with that respond to immunosuppressive treatment, up to infarction and severe life-threatening myocarditis. Pericarditis and endocarditis may also occur. Actually, so 1 month ago, I was confronted by a young man coming with the manifestation of MI, and I diagnosed him as a sort of vasculitis, and actually the patient responded well, and all the ECG data disappeared after immunosuppressive treatment. Now we come to the nerve, peripheral neuropathy, usually with mononeuritis multiplex pattern, is the most common neurologic manifestation and is the most frequent, especially in eosinophilic type. CNS system involvement is less common and most often is manifested as vasculitis within the meninges. Now we come to the gastrointestinal involvement, typically causes abdominal pain, blood in stool with mesenteric ischemia and renal intestinal perforation. So it can present as acute abdomen and bleeding per rectum. Vasculitis in the pancreas and liver can mimic pancreatitis and hepatitis symptomatically and cause elevation of serum pancreatic and liver enzyme. This is the picture of perforate vasculitic rash with ulcer, a patient with vasculitis. Another photograph showing cutaneous vasculitis. And this is the famous indirect immunofluorescence staining of peripheral lymphocyte normal neutrophil when examined by patient against patient serum by direct immunofluorescence. Either it will show the proteinase 3 in cytoplasmic C ANCA, proteinase 3, and or the myeloperoxidase in perinuclear type of ANCA. And this is the frequency of organ involvement in different type of vasculitis. We added, besides our 3 type of ANCA associated, we added IgA-related vasculitis and the cryo, since they are common. And you see that kidney is frequently involved in these first 2 lesions. And pulmonary cutaneous will be more in IgA and the cryo, and lung involvement is very common, especially in eosinophilic granulomatosis. So all organ involvement, but with different incidence. Now, regarding the laboratory testing of ANCA should include both indirect immunofluorescence and ELISA staining. Although positive results are rare in completely healthy individuals, approximately 1/4 of patients with other inflammatory renal disease, especially lupus, for example, will show false positive immunofluorescent staining. Usually it is B ANCA. This put question regarding the specificity of this lesion. ANCA may be positive also in inflammatory conditions other than vasculitis, such as inflammatory bowel disease, rheumatoid arthritis, chronic inflammatory liver disease, bacterial endocarditis, and cystic fibrosis. So again, question regarding the specificity of the lesion, but it is highly sensitive for diagnosis. ANCA testing has a good sensitivity for ANCA-associated vasculitis. Patients with concurrent ANCA and anti-Gbm disease antibody have a worse prognosis than patients with ANCA alone. This will call for more aggressive treatment. This is the pathogenesis of ANCA-associated vasculitis. It is very interesting, but we can classify it either this is the normal neutrophil, then this is the primed neutrophil by cytokine. This is the stimulation of the activation of complement pathway, and this is the inflammatory neutrophil stick to the vascular endothelium will call the different type of leukocyte and deposition of fibrin. This is the acute phase of vasculitis. Later on, macrophage will come to the lesion and fibrosis occur. So it is priming normal neutrophil, prime neutrophil, activation of a complement pathway, sticking to the endothelium, acute inflammation, and chronic phase of ANCA-associated vascular. And this is a histology of a patient with ANCA-associated glomerulonephritis. This is a glomerulus showing segmental crescentic segmental necrotizing glomerulonephritis with crescent. Another, this is arteritis showing arteritis in patient with vasculitis. And this is a chronic phase, and this is a glomerulus beside necrosis. There is fibrosis of the glomerulus sclerosis, and circumferential fibrous crescent, advanced stage of ANCA-associated vasculitis. Regardless the category of ANCA disease, the best clinical predictor of renal outcome is the glomerular GFR at diagnosis. Now we come to the differential, how to differentiate between these different types. For example, all these types have a vasculitis, okay? But if we are going to talk about IgA dominant deposition, it will be in the IgA vasculitis. If we talk about cryo deposit, whether in the blood, peripheral blood or deposit, you will see it in cryoglobulinemic vasculitis. If you look at ANCA, we have these three types are positive. About necrosis, you have this two type, but if you are going to talk about eosinophil, you have only the eosinophilic type of granulomatosis with vasculitis. Now we come to the treatment. The goal should be not to over-treat mild disease and not to under-treat a severe disease. This is the wisdom. Treatment involves three phases: induction of remission, maintenance of remission, and treatment of relapse if it occurs. Okay, let us come to definitions. This is the definition of complete remission, partial remission, when we say it is partial remission, and this is the definition of relapse. And now to assess the patient, assessment of disease activity to balance the decision-making, how far to be aggressive, approach to initial therapy that depends largely on the severity of disease, and of course, besides this, other factors that may influence initial choice of therapy include patient-specific factors. If we talk about organ-threatening or life-threatening disease, this includes pulmonary hemorrhage, cerebral vasculitis, progressive peripheral or cranial neuropathy, orbital pseudotumor, scleritis, gastrointestinal bleeding tube vasculitis, cardiac disease due to vasculitis, as pericarditis and myocarditis. But at the same time, non-organ threatening or non-life threatening disease, we may say patients with the non-organ or non-life threatening disease have no evidence of active glomerulonephritis, and none of the organ threatening or life threatening manifestation which I have presented in the previous slide. Such patient may have, of course, may present rhinosinusitis, arteritis, and or pulmonary nodule. Okay, an non-organ threatening and non-life threatening disease can still result in a substantial disease burden and long-term damage. So we have to keep observing, keep evaluating this patient. If we come to induction, the consensus is that corticosteroid alone are not as effective for induction therapy as corticosteroid combined with cytotoxic agents such as cyclophosphamide. So we should go by these two agents. Combined treatment with corticosteroid and cyclophosphamide induces the remission in approximately 75% at 3 months, but it can go up to 90% at 6 months. So good effect. The specifics of combined induction regimen vary with respect to, of course, the agent, dose, route of administration, and duration. One induction approach, for example, is to begin with 7 milligram per kilogram body weight intravenous methylprednisolone for 3 days, followed by oral prednisone. But we can give even sometimes longer duration if we have very severe disease. Then we go oral 1 milligram, then tapering the dose to finish at 3 to 5 months, according to the disease activity, how far serious, and the degree of response to treatment. Corticosteroid treatment is combined with 2 milligram per kg body weight oral cyclophosphamide or IV cyclophosphamide at half gram per square meter surface area per month, adjusted upward to 1 gram on the base of leukocytic count after 2 weeks after each injection, with a target nadir of 3,000 cells per nanometer. The dose of oral cyclophosphamide can be reduced by 25 milligram for patients older than 60. So age can affect the dose. The dose and duration of prednisone therapy varies and may be influenced by the rate and extent of disease remission. A meta-analysis concluded that longer course of glucocorticoid are associated with fewer relapse. Okay, this is very good. This may explain relapse when you are given under treatment. The goal is to discontinue prednisone after 4 to 5 months if, and this is if, remission has been induced. Continuing prednisone beyond 6 months is associated with increased risk of infection and may not provide significant benefit. But again, personalization is very important. You have to judge how far it is risky to continue, but how far risky if you withdraw the drug earlier. Cyclophosphamide oral versus pulse trial. This is Cyclops trial. Actually, they tried oral versus intravenous, and they found that the two treatment groups had no difference in time to remission, renal survival, mortality, or adverse events. So this may favor use of IV pulse because of the reduced cumulative dose of immunosuppressant. And as Dr. Ala said, in Egypt, or Muhammad Karan said, in Egypt, unfortunately, we don't have oral. So usually we go directly to the intravenous regimen. Now we come steroids, cyclophosphamide, then we go to the third important treatment modality, which is rituximab, which is a monoclonal antibody targeting CD20 on B lymphocyte, is an alternative to cyclophosphamide. There is a big trial. This is the RAV trial, which compared a controlled prospective clinical trial comparing rituximab versus cyclophosphamide, we have this RAV trial, and we have rituximab trial, and actually they found a non-inferiority of rituximab when compared to cyclophosphamide. Both trials showed that rituximab was not inferior for inducing a remission compared to IV cyclophosphamide or oral cyclophosphamide, and this trial led to the approval by FDA approval of rituximab for treatment of anti-acidic vasculitis. And this is the story of RAV trial. You can read it against oral cyclophosphamide. And this is the continuation of RAV after induction of remission. They continued by rituximab. And this is the other trial, which we call rituximab, in which they compared cyclophosphamide versus IV versus cyclophosphamide. Okay, so rituximab is a good alternative to cyclophosphamide. If we come to the rituximab-based regimen, if a rituximab-based regimen is selected, and actually we recommend this, either the dose regimen used for rheumatoid arthritis, in which we give 1 gram rituximab IV over 5 hours, and you can repeat the second dose after 2 weeks. Or you use the other regimen in which we give 4 doses. You give 500 milligrams. This is the dose 375 milligram per square meter surface area weekly for 4 weeks. These are the 2 regimens. Of course, besides rituximab, we give glucocorticoid. But this is a very important notion, this one. You should avoid rituximab or use it with conjunction anti-hepatitis B virus therapy in patients who are positive for hepatitis B surface antigen or antibody to hepatitis B core antigen. So before giving rituximab, look for hepatitis B virus. Okay. Either not to give, or you give it with one of the drug acting against B virus. Cyclophosphamide-based regimen, if cyclophosphamide-based regimen is selected, the choice of oral versus intravenous is largely dedicated by practice style. Actually, as I said, in Egypt, we use intravenous. Both oral and intravenous regimen are highly effective. Some clinicians prefer IV cyclophosphamide given the lower cumulative dose associated with this administration and the theoretical subsequent low risk of toxicity. After approximately 3 to 6 months, cyclophosphamide is replaced by a medication with lower risk toxicity, either azacitidine or less effective MMF. Regarding intravenous cyclophosphamide dosing, there are many modes by which you can give cyclophosphamide. Actually, we prefer either to give bi-weekly dose or monthly dose over 6 months. This is the monthly dose, okay? And bi-weekly we give half gram every 2 weeks. But again, you have to modify according to GFR and according to the patient age and according to the white count. What about MESNA when using intermittent pulse of cyclophosphamide? Some clinicians concomitantly administer mercaptan ESN sulfonate, which we call MESNA, to prevent cystitis, although the efficacy of this approach is unproven. Okay, and of course, it may be effective, it may be mandatory with oncology, and where they use bigger dose of cyclophosphamide in their treatment. But our dose in glomerulonephritis still a smaller dose to induce this cystitis. Actually, I faced this cystitis a few times in my career. So we don't use it as a routine. Regarding oral cyclophosphamide dosing, if oral cyclophosphamide is used, it is typically given in a dose of 1.5 to 2 milligrams per kg per day, with appropriate dose reduction made in older adults and in patients with impaired kidney function. The therapy is continued until a stable remission is induced, which is usually achieved within 3 to 6 months. Then the white blood cell count should be closely monitored, i.e. weekly, and the cyclophosphamide dose should be adjusted to avoid severe neutropenia. The white blood cell count should remain about 3,500 per microliter, and absolute neutrophil count should remain about 1,500. Patients receiving oral or IV cyclophosphamide should also receive, of course, glucocorticoid as rituximab. If we come to the glucocorticoid dosing and tapering, oral glucocorticoid therapy typically start at 1 milligram per kg, maximum 60 to 80 milligram per day, oral prednisone, and or its equivalent for most patients with organ or life-threatening disease. High dose or basic glucose, such as methylprednisolone, 7 to 15 milligram per kg to a maximum dose of 1 gram per day for 3 days, are usually limited to patients presenting with manifestations such as rapid Glomerulonephritis, pulmonary hemorrhage, mononeurus multiplex, or optic neuritis. Daily oral glucocorticoid are then started after IV therapy. And this is the, if we look to reduce dose of glucocorticoid tapering regimen in patients with granulomatous and microscopic Arteritis. And this is a different patient weight, and this is the time frame and how to decrease the dose. So the maintenance dose usually 5 milligrams. Role of plasma exchange. All authors agree with the use of plasma exchange for most patients with granulomatous and microscopic who are concomitantly positive for Anti-Gbm disease. Okay. Some other authors would also offer plasma exchange to patients with granulomatous and microscopic who present with pulmonary hemorrhage, while other authors would reserve the use of plasma exchange for patients with pulmonary hemorrhage not readily responding to other therapies. So you try other therapy first. With failure, give it some plasma exchange. But if you ask me personally, in a serious condition like this, if it is available, I will do plasma exchange. When to use plasma exchange to treat patients with granulomatous and microscopic with active kidney disease is controversial. Data are mixed on the benefit, but the use of this therapy is reasonable for patients with severe kidney disease, e.g. those who have a serum creatinine more than 4 or who require TANs, with some expert instituting such therapy immediately upon identification of such situation, and others first consider the response to initial compound heavy therapy with glucocorticoid and rituximab or cyclophosphamide. So the same attitude there. If plasma exchange is used, we suggest 7 sessions over 2 weeks. So alternate day of 60 milliliters per kilogram at each session. Albumin is a preferred replacement fluid in patients without bleeding or recent biopsy. Since with plasma exchange, you remove anticoagulant. A bleeding can bleed after biopsy. So we give albumin. But if there is in a situation like this, you will give fresh frozen plasma. For patients with risk bleeding or recent biopsy, we suggest that 1 to 2 liters of fresh frozen plasma be substituted for albumin at the end of procedure, the last 2 sessions, to reverse pheresis-induced depletion of coagulant factor. Important. For patients with active hemorrhage, the replacement of fluid should exclusively be by fresh frozen plasma. This is important. Among patients who develop severe infection in the setting of plasma exchange, a single infusion of IVIG, 100 to 400 milligram per kilogram, can be given to partially replenish antibody level. to prevent or to control infection. This is very important. Now we did induction. Are there alternatives for what we said? Yes, there are some alternatives. For example, some may give rituximab plus cyclophosphamide, but we need further studies to confirm value of this regimen. Another new option, which is the avacopan. Some physicians, some clinicians use this C4A receptor inhibitor, avacopan, as an adjunctive agent with standard induction therapy to limit use of glucocorticoid. Avacopan is administered orally, 30 milligram orally, twice daily, typically in combination with a shorter, reduced dose of glucocorticoid regimen, in which glucocorticoids are tapered over 4 to 6 weeks, not months, depending upon the patient response. So this is a new agent. Use of avacopan should be avoided in patients with active, untreated, and or uncontrolled chronic liver disease, and in patients who are taking moderate to strong cytochrome B inducer. The dose should be reduced to 30 milligram daily in patients who are taking strong cytochrome B enzyme inhibitors. Now, with the remission, how to maintain. Once the remission has been induced, continued lower immune suppressive, lower level immune suppression is needed for most patients to prevent relapse. So this is a question, how to prevent relapse? Which usually entail a low dose glucocorticoid plus additional immunomodulatory treatment such as azacitidine or rituximab or MMF for 12 to 15 months. See, this is how to prevent relapse. Maintenance therapy should be for a shorter interval or not required for patients with lower risk of relapse, such as patients with MPO ANCA, who have myeloperoxidase ANCA, who have complete remission, and those with myeloperoxidase negative. Okay. More prolonged maintenance may be appropriate for patients with increased risk of remission, this type of ANCA. Prior recurrence or presence of renal involvement. Sustained use of cyclophosphamide is not recommended because of toxicity. A randomized controlled trial comparing cyclophosphamide for 12 months with maintenance therapy with AZA once complete remission is attained, or to continue cyclophosphamide demonstrated no difference in outcome, including relapse ratio. So when you lose remission, switch to azacitidine. Compared with azacitidine, maintenance therapy with MMF was associated with significant higher rate of relapse with MMF. Nevertheless, MMF remained an option for maintenance therapy in patients who are intolerant or allergic to azacitidine. Methotrexate may be useful in maintaining a remission in patients with bile disease and no renal impairment, since it is potentially nephrotoxic. What about rituximab? This is a good option, is another option for maintenance. The maintenance of remission using rituximab in systemic ANCA-associated vasculitis trial, compared rituximab. So they use rituximab 500 milligram every 8 months, 6 months, to azacitidine for remission maintenance in patients with small vessel vasculitis and granulomatous in complete remission after induction. So after induction, to give rituximab every 6 months, you give a dose or continue azacitidine in this disease. Rituximab was better than azacitidine for preventing the relapse, including renal relapse. This is another way. Okay. Relapse therapy, approximately 1/4 to 1/2 of patients with ANCA-associated vasculitis will experience a relapse within several years. So it is expected. In a perspective observational studies from a glomerular disease collaborative network, the relative risk of relapse was increased in those individuals who had PR3 ANCA and respiratory tract disease. Patients had more than threefold risk of relapse compared to those with myeloperoxidase ANCA and without lung or ear and nose or throat. And increased in ANCA titer increases the likelihood of relapse, and some also advocate preemptive immunosuppressive therapy if ANCA titer increased by at least fourfold. Another thing. Other group prefer to identify clear-cut clinical or pathologic evidence of relapse before increasing immunosuppressive therapy. Observational data suggests that the best treatment for relapses may be rituximab, as I said, 500 milligrams every 6 months. There is a mounting evidence that use of rituximab for relapse is superior to cyclophosphamide. Reinstitution of treatment similar to an induction regimen is used the most often, but less intensive and less toxic therapy may be adequate. In addition to rituximab or cyclophosphamide, a number of therapies can be used in the treatment relapse, including azacitidine, MMF, methotrexate, or combination of these drugs tailored to the individual patient with recalcitrant disease. In those who have a much smaller risk of relapse, all therapies may be stopped, provided the patient and physician pursue a monitoring course in which the risk of early relapse is identified, such as home urinary dipstick looking for microscopic hematuria. The risk of relapse is about 10 to 15% even with remission maintenance therapy. The role of antimicrobial agents such as trimethoprim sulfamethoxazole in maintenance of remission is controversial. Some studies have suggested a benefit, but others have not because of an increased likelihood of relapse. Okay, by the way, you can use these drugs. Ciptrine may be used as adjunctive therapy, especially in patients with upper respiratory disease, but should not be used in absence of immunosuppressive drugs with more proven efficacy as cyclophosphamide and azacitidine. Now we come to ANCA-associated vasculitis and kidney transplantation. Renal transplantation is not contraindicated in patients with end stage caused by ANCA-associated vasculitis. In a multi-center experience, the vasculitis relapse rate was 1.2% per year, so it is very uncommon. A positive ANCA titer at the time of transplantation does not increase the risk of recurrent disease in the transplant. So far, clinical intervention decided. And of course, titer is not very hard. Recurrent Anti-Gbn in renal transplant responds similarly to recurrent disease in native kidney. As with native kidney disease, an increase in ANCA titer and an active urine sediment should be suggested, should suggest recurrent glomerulonephritis, but diagnosis require a pathologic confirmation, of course. Now, Mr. Chairman, dear colleague, I can now come to the conclusion. I will say prompt diagnosis and the rapid initiation of effective treatment are the important factor for optimum outcome in patients with ANCA-associated disease. Current management strategies are superior to those in earlier decades because of more effective, more targeted drugs and treatment regimen that are more personalized to the nature of the disease in individual patients. Ongoing advances in understanding ANCA disease mechanisms and development of more effective, less toxic, and more targeted therapies undoubtedly will lead to even better outcome in the future. In addition to rituximab, cyclophosphamide, a number of therapies can be used in the treatment of relapse, including AZA, MMF, methotrexate, or combination of these drugs tailored to the individual patient with recalcitrant disease. And thank you.
Thank you so much, Dr. Sob. And in fact, I would recommend to all the audience, if they don't mind, print, and I think Dr. Al-Husseini is going to send you the presentation and your slides, because that was really quite comprehensive and detailed, and not only that, clear in your thoughts, and it's very, very good for a learner to have it. So I recommend that for you guys, and I would leave the discussion to be part of the case that we are going to present. So leave your questions if you have any after Dosaji present his case. It would be all related. And in fact, couple on the chat you already answered, Dr. Sob, that they can find the answer that's on the chat. Now, is Adam with us, or? So Dr. Dosaji, yes, Dr. Dosaji is a first-year fellow with us. He's a combined program of nephrology and critical care medicine. He's trained in England, so I'm pretty sure the Egyptian will appreciate his accent very much, as you are used to it much more than the American accent.
Okay, so I'm going to present a case. It's called Just One More Exchange. This was it became a little bit of a mantra that we kept promising this patient, just one more plasma exchange. This is a very interesting case. 62-year-old male with a past medical history of coronary artery disease, hyperlipidemia, and hypertension. He was seen by an outpatient cardiologist for blood pressure management and secondary prevention for coronary artery disease. The cardiologist started him on hydrochlorothiazide and losartan. 1 week after starting hydrochlorothiazide and losartan, the patient reported that he was feeling dizzy to his PCP. So the PCP got outpatient labs and found that his creatinine was 4.0. Previously, this gentleman had a very stable baseline. His creatinine had been 1.0. He had been very stable for a long period of time. So the PCP was quite worried and asked the patient to go to an outside hospital emergency department. At the emergency department, the patient was thought to have a pre-renal AKI because of the hydrochlorothiazide and the losartan. So they discontinued those medications and they placed the patient on IVF. They kept the patient overnight and they repeated the labs in the morning, and the creatinine had dropped from 4.3 to 3.7. So in the emergency department, the thought was that this patient likely had a pre-renal AKI secondary to these medications, and no further investigation was done, despite the fact that the patient had a UA in the emergency department that was potentially quite worrying. He had some hematuria and some proteinuria in that. 1 week later, the patient had a post-ED follow-up at the PCP's office and was found to have a creatinine of 3.9. The PCP referred the patient to outpatient nephrology office. This is when we get involved. So at the beginning of July, the patient visits the outpatient nephrology office. He has healthcare maintenance in the past. He had refused colonoscopies and cancer screenings in the past, just out of personal preference. He had a family history of Sjogren's, common variable immune deficiency, so on his mother's side. No illicit drug use. Noted to have 300 proteinuria.
Adam, this is going to become very important for the case. Can you tell us a little bit about social history? Are you sure there is nothing exposure? What can you tell us about his lifestyle or something? Because really, we got the gist of the case. You can go fast on it, but what we want.
So So the gentleman did have a extensive history of formaldehyde exposure.
There you go.
So he worked at a funeral home and he had a formaldehyde exposure. That was the only social history. But actually, we didn't know this at the time of the office visit, and it hadn't been discussed or hadn't been brought up at the time of the office visit. This social history came once he was admitted. We found out about the formaldehyde exposure, and so he worked at a funeral home and was an embalmer.
Got it. Okay, you can proceed. Okay.
Yeah. So based on this proteinuria and the blood, basically had a very simple dipstick UA at the emergency department. There was a suspicion that he had RPGN. So he was sent for further lab work, which was an ANA, a dsDNA, RNP, ANCA, NPO, PR3, SSA, SSB, Smith, Anti-Gbm, C3, and C4. So these were the initial labs. He had these labs done on the day of the visit. He went down from the clinic to the lab, had the labs drawn, and then these were the results of the lab. So he had a hemoglobin of 8.1. So this was a new anemia. It was normocytic, normocytic, normochromic anemia, creatinine of 3.47, BUN of 34. This was his UA. So blood in the urine, large amounts of blood in the urine. So RBCs 30 to 50, which is significant. Protein in the urine greater than 300 on the dip, which was consistent with the emergency department visit. And then in terms of quantification, a protein to creatinine ratio, spot protein to creatinine ratio of 2.1 grams. So a significant amount of proteinuria and blood in the urine. So pretty suspicious for RPGN or a GN at this point. So 4 or 5 days later, some of the serology started coming back, and this was the serology that came back. So ANA was detected, ANA pattern was speckled, ANA titer was very high, 1 to 640 is one of the higher ones that I've seen for sure. GBM, anti-GBM was positive, C-ANCA was extremely positive, MPO was positive, and PR3 was positive. So pretty across the board positivity, which is, I mean, it's fairly unusual to have so much positive. So at this point, our differential, we had an unclear etiology, previously suspected to be pre-renal, but it didn't improve with IV fluids or holding the medication. He was on Celebrex, that was held, no real effect, no improvement. So at this point, there was a suspicion of an RPGN. We didn't suspect SLE so much, we were more suspecting drug-induced. And the reason why we were suspecting drug-induced was because of the number of serologies that were positive. Okay, so
what did the biopsy show?
Hold on, we'll get to that. I've got some beautiful photographs, but I'm going to get to the biopsy at the end. So the management plan. So the plan was to have an outpatient renal biopsy, followed by transition of the patient to go to an outpatient infusion center, initiate pulse dose steroids, and then rituximab, 375 milligrams. Sorry, that's a typo. It should be milligrams, once weekly for 4 doses. Okay. So the patient had the biopsy on the 24th, and then was due to go to the outpatient infusion center the next day. At the outpatient infusion center, the patient's labs had deteriorated significantly. So his hematocrit was 19.8, his hemoglobin was 6.7 at this point. His creatinine was 9.89, his BUN was 77, And based on this deterioration, it was decided that he wouldn't be suitable for outpatient therapy, and that actually this patient should be admitted. So the patient was directly admitted to the hospital. A right IJ was placed, and he was initiated on Plex with FFP. He was started on pulse dose steroids. So this was 1,000 milligrams of sodium medrol for 3 days, followed by prednisone 80 milligrams once daily. Was started on cyclophosphamide. His G6PD screen was negative, and that came back fairly quickly. So he was started on dapsone for prophylaxis, infection prophylaxis. And his anti-Gbm titers were followed, and they became undetectable after 4 treatments. After 6 Plex sessions, patient was started on rituximab. Okay. Despite 6 sessions of Plex and prednisone 80 milligrams once daily, cyclophosphamide 75 milligrams once daily, and rituximab, the patient developed acute hypoxic respiratory failure, rising anti-Gbm titers. Patient was transferred to the ICU, and in the ICU was intubated. They did a bronchoscopy, and the bronchoscopy was in keeping with diffuse alveolar hemorrhage. So the patient was started on Plex daily for an additional week, and renal function in the ICU deteriorated further, and patient required intermittent dialysis by this point. So prior to discharge, the patient had a total of 21 sessions of Plex, 3 doses of rituximab. So it took, and this whole time he was on 80 milligrams of prednisone and cyclophosphamide, which intermittently had to be stopped because of severe leukopenia. But it took a significant amount of therapy to get this patient under control and in a position where he could be discharged. There was a period of time when we thought that we had him under control and we were planning for outpatient discharge. He had supposedly his last dialysis session in our dialysis unit before we were going to discharge him, and he decompensated in the dialysis unit and had a further episode of DAH. So this was a very difficult to manage glomerulonephritis with pulmonary involvement. So now I kind of want to come to the pathology. So this was his H&E stain. It's a 20 times view. And I know you can kind of see the little captions, but this showed kind of a cellular crescent. And then if anyone has any other additional comments, otherwise I'll move on to the next slide.
This is obviously an impressive crescent, almost crushing the whole glomerulus. It's almost a full moon, not a crescent, but but it is really crushing it now. That's clearly has it, and you can see red cell cast also nicely presented in the tubules.
So I mean, this is a really beautiful slide. I mean, considering all things, this is like a slam dunk kind of slide.
Like the first case, also you can see ATN picture on it too.
Yeah.
And she's sloughing the tubules. Look at the tubule, how thin they are, simplified.
Yeah. And then simplification of the tubules here.
And what's the next slide you showed us next?
So this is a 20 times view showing arteritis with transmural fibrinoid necrosis and leukocytic inflammatory infiltration. So this kind of showing the blood vessel in kind of full view.
And a very impressive fibrinoid necrosis. You can see it right there in the medial wall. I mean, that's so, and it's a pretty also sizable vessel, as I think the first speaker was mentioning, you know, the size of the vasculitis. And so this is really not only glomerulus and small vessels, it's almost getting to a bigger blood vessels. I mean, we got the picture of your case, and obviously we have limited time now, but it really deserved Good discussion. And here you are showing us linear deposits, correct?
Yeah, so actually, I know that we're a little bit short of time, but some of these photographs are absolutely beautiful. One of them I even have printed out and have on my desk at home. This is the linear GBM staining in the glomerulus with a crescent. And then this is a 4D times view of GMB staining.
And up to date, always look for pictures, please. You can submit to up to date and they will take you. I mean, they all look for slides like this.
I mean, this really is a beautiful picture. This is really a slam dunk diagnosis. And then this is the albumin view. And then this just for completeness. So the electron microscopy showed no evidence of complex immune deposits. So the electron microscopy, but this is just, honestly, this is just for completeness sake, is the electron microscopy.
So the gist of this case is when we have pan-positive serology for vasculitis, ANCA, Anti-Gbm, I mean, ANA, I mean, you name it, everyone, including anti-histone.
Yeah.
And our good friend and the moderator tomorrow, Dr. Neckman, he mentioned it to me when we were discussing that when you have that, you'll be suspicious of a toxic injury of some sort. And I didn't know that he was exposed to formaldehyde. And the question, what do we know about formaldehyde and vasculitis? Have you searched the literature? I have not. So
there's like pretty limited data. Like we're talking about an extremely rare condition with an extremely unusual environmental exposure. So it's kind of at this point, it's like there aren't even too many case reports of this, to be honest. So I don't really know how much of an effect this had. The timing also isn't necessarily great because a lot of that exposure happened early in life, and this kind of is much later. So I don't even know whether that is, that was the smoking gun, if that makes sense.
Any, Amer, you want to comment something?
Yeah, again, it's an interesting case. The problem is we don't know what is the trigger. Is it really a formaldehyde or something else? But whatever the trigger is, of course, we need to deal with whatever we have. This patient has a very bad vasculitis, and I think the good question is, for how long, do you want to treat him with plasma exchange and other immunosuppressive medications?
But if that goes back to Adam, when you're saying he was not doing well, it's only lung involvement, correct? So the therapy was directed just for the lung, because forget about the kidneys, you saw the biopsy.
Yeah, so actually, but it was very interesting. Initially, it was like a salvage for the kidneys, but then as he decompensated further and became essentially dialysis dependent, it became about lung-directed therapy. And actually, it was trying to keep him off the ventilator or in a position where they could stop the bleeding enough that they could extubate him. So that kind of became the direction of the therapy.
And how long he's been discharged now? Again, since he hasn't had any exposure, if you think it is related to exposure, and we really plasma exchange him quite a bit. By the way, for the audience, tomorrow we have a special lecture just on plasma exchange in vasculitis. So I'd recommend you to come back tomorrow, please, and listen to Dr. Ahmed for that particular topic. So
it's been 10 months since his discharge.
And there was no recurrence of his lung lesion?
No, so he has been hospitalized a couple of times, but no recurrence.
That goes with the theory of exposure to something.
Yeah.
Although anti-Gbm usually is not relapsing, as Dr. Sobah just mentioned.
Yeah.
Very challenging cases. I mean, all the cases and discussion was, tough cases today.
It can be an irritant to lung epithelial tissue, but I haven't, I was actually looking whether there's any case reports. One of the teaching points that I also want to throw here is like when you have anti-GBM, but when you have also like bigger vessels, you see bigger vessels involved on biopsy, then it's mandatory to check ANCA because you would not expect like bigger vessels to be affected by anti-GBM antibodies. So in these cases, like they combine the worst of both diseases, and they tend to do very poorly.
And as we're concluding, Adam, we really need to not only publish this case report, but also I have another case that I'm pretty sure it's smoke inhalation related. Again, young man that has fire in his factory, and I have pictures of him into the smoke, and then he comes in with a vasculitis, again, ANCA vasculitis. I think, you know, we need to be more aware of environmental factor causing vasculitis.
Right. Thank you so much. And I think this is the time to
thank you very much, Adam, for this very interesting case. My comment to my Professor Sabh. As usual, Professor Sabh, very comprehensive presentation. I just have two comments. As Dr. Sabh had discussed the pathophysiology of ANCA-associated vasculitis, it is, as he said, it is not fully understood till now why the neutrophil, or why there is loss of tolerance to the neutrophil, and there is formation of antibodies against the neutrophil, and also many players like the complement. And I think in the future, based on the result of the CLEAR trial using the avacopan, I think maybe the use of avacopan may change the picture and the prognosis, I mean renal prognosis of ANCA-associated vasculitis. The second comment about the use of plasma exchange in treatment of ANCA-associated vasculitis, I think the debate is still there, because we have two fingerprints trials, the MEPEX and the BIG-CVAS trial. And Erie Roberts from the MEPEX trial was encouraging actually. However, the long-term follow-up of this patient found that the use of plasma exchange is not superior to those who received methylprednisolone. And the result of BIG-CVAS trial, I think, reached to the same conclusion. Tomorrow we'll have a very interesting lecture about plasma exchange in ANCA-associated vasculitis, and I hope it will solve this debate.
Thank you so much, Dr. Sabri. Just for the sake of the time, we're going to move, you know, because we only have 60 minutes to conclude and to finish our, you know, nice meeting today. So Lori Gill is going to discuss with us the questions and try to answer it and explain why she chose these best possible right answers. Go ahead, Lori Gill.
Great. Okay, so question number one, what is the expected immunofluorescence staining for anti-GBM disease? Do we all want to chime in and try to figure it out, or do you want me to just go ahead and say the answer?
Go ahead, please. Yeah.
Just go ahead.
Yes.
Okay. So the answer to this one is the linear uptake of IgG, and we all know in anti-GBM, the primary target is type 4 collagen. There's a triple helix, alpha type, subtypes 3, 4, and 5, and it's really the domain in alpha 3 helix that's the main target of these this IgG antibodies. And so what you see then in immunofluorescence is this nice linear uptake of IgG around the basement membrane. Question number two. Anti-Gbn disease accounts for what percentage of crysenteric GN cases? So this is kind of just a finding and based on the data that we've collected over time. As we know, anti-Gbn disease is the incidence is pretty low, actually. It's 1.6 persons per 1 million in terms of population. So it's relatively rare. But what percentage is crescenteric GN in anti-Gbm? It's actually pretty low, 10 to 15%. What's I think unique here is that when we look at the crescents, they're typically of uniform in age. And I think that's one of the distinctions for anti-Gbm. Question number 3. I thought this was a pretty interesting question. What monoclonal antibody therapy is associated with subsequent development of anti-Gbm? So A, is it bevacizumab? This is an anti-VEGF inhibitor. It usually helps with inhibiting microvascular growth. Alemtuzumab or Campath is a monoclonal antibody that essentially binds to T regulator cells that induces lymphocyte depletion. Adalimumab, which is another monoclonal antibody that binds to TNF alpha, which leads to mononuclear cell apoptosis. And then trastuzumab, this also is a monoclonal against epidermal growth factors that again leads to apoptosis of the cell. The answer here is Campath. And the thought behind here is that, you know, once you deplete all your lymphocytes, it's really the repopulation of T cells after depletion that goes back in attacking the epitopes on the alpha-3 helices. So when you repopulate your lymphocytes after depletion of alemtuzumab, that revs up your immune response again. That leads to the subsequent development of the anti-Gbn pathogenesis. Question 4. What percentage of patients with anti-Gbm disease will have pulmonary hemorrhage? As one of our talks earlier, you see a lot of pulmonary hemorrhage in anti-Gbm. So you could probably think about 50 to 60% of it. And turns out that that's the rate that we see. About 30% is renally limited. Question 5. For patients with anti-Gbm disease who are dialysis independent or have diffuse alveolar hemorrhage, plasma exchange falls into what recommended category? Keep in mind that category 1 is considered first line and that we should do it. And category 4 is considered harmful or even contraindicated. So over here, when I answered these questions, I went through the guidelines for apheresis that we use for clinical practice. It's by Plasmapheresis and company. So if you want to just Google that guideline, it'll kind of go through the different categories and indications for plasmapheresis. And they'd recommended that for those that are independent of dialysis and have, you know, diffuse pulmonary hemorrhage, which means that the anti-Gbm is pretty severe, we should do plasmapheresis. Now, whether it's helpful or not is up to another debate, as we talked about, like the Paxivest trial, which they did in ANCA patients. It showed actually that plasmapheresis had no real effects, but I guess the utility of it and the efficacy, whether or not it really makes a difference, is up for debate. But if it's available, it shouldn't be harmful, and so they're recommending to go ahead and do it. Question 6, for patients with anti-Gbm disease who are dialysis dependent or who have a serum creatinine that is pretty high at 5.7, plasma exchange falls into which recommendation? So here it seems like we don't have a lot of GLOMs to save, and what the apheresis guideline is saying that yes, we can do it, but it's not really high up. It's not urgent to do plasma exchange. And, you know, if we have it, it's not contraindicated. So it falls into the category 3. According to data from the University of North Carolina, which clinical pathologic phenotype is most likely to relapse? Here, I think we all have an idea that it's likely the PR3C ANCA positive patients that are most likely to relapse. And the kind of the reasoning they thought about here is that, you know, PR3 pretty much affects a lot of their organ systems, and that it affects most the lungs. And in textbooks, about, you know, 90% of PR3 positive patients have lung involvement. And so just the positivity and the pulmonary findings we find in PR3 positive patients make them more likely to relapse. Question 8, microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. All 3 have a peak incidence in which of the following age groups? As we think about these age groups, it's usually these 3 diseases occur in populations who are 50 years old and older. But when you lump all 3 together, it seems like these 3 disease processes happen more in persons aged between 65 and 75 years old. And finally, approximately what percentage of patients with anti-GBM disease will have ANCA, typically MPO ANCA positivity? Turns out that it's about 35% that will have findings of both MPO ANCA and anti-GBM. And we know that from previous studies, we thought that maybe the ANCA-induced glomerular inflammation may trigger the development of anti-GBM by exposing anti-GBM epitopes. And so there's usually a little bit of overlap between these 2 antibodies that may open up the epitopes for the other antibody. So I hope that was a good review in terms of just recognizing the different incidences of these different disease processes. Thank you all.
Thank you so much, Lori Gill. A very nice question and a good explanation with very clear take-home messages. I think this will conclude our day today. Thank you so much for everyone who participated in our meeting today. And tomorrow, please join us tomorrow at the same time. We are going to start at the same time at 8 p.m. Cairo time, 2 p.m. Eastern time. We are going to have great case discussion and presentation. We have 2 cases will be discussed, probably about lupus and RBGN, very difficult cases. We have 2 great speakers tomorrow, Brad Roven, the chief of the nephrology division at Ohio State, and we have Ahmad Siddiq from University of Kentucky. So we have 2 great speakers. Brad is going to talk about lupus nephritis. Siddiq is going to talk about plasma exchange in RBGN and vasculitis. We have Patrick Nachman from University of Minnesota will moderate the discussion with Dina Shaheen and Dr. Abdul Wahab. So please join us tomorrow. I cannot thank enough everyone who contributed today. Of course, included all participants, audience, Peter Sawaya, Sahar Kubar, and of course, our professor, Dr. Sobh, Dr. Nassar, and our fellows, Lori Gill, Adam, and Asma. Thank you, everyone. And if Dr. Sawaya or Dr. Sabri or Dr. Kubar wants to say something, then we can conclude.
Thank you, Amr. I just want to say that Sahar left a nice bibliography in the chat. If the audience can print them or take picture of them or something, so you can have more references for you for the future.
Very nice, very nice. Sahar?
Thank you, everyone. Nice participation from everyone, and looking forward to see you all tomorrow, inshallah.
Thank you, thank you. Dr. Sabri, you are muted.
Thank you very much, Dr. Amr. Thank you for the moderators, for the speakers, and of course for the elegant audience. Thank you very much.
Okay, we'll see everybody hopefully tomorrow, and have a good night.
Bye.
Bye.